Well, good morning, everyone. My name is Bob Suter. I'm Vice President of Quality for the American Heart Association and a professor at UT Southwestern in Dallas. I'm very honored to be here speaking with all of you this morning about the critical role of emergency care systems development for global health. I have no significant disclosures other than employment. And really, emergency care as part of the global health development has been perhaps neglected historically because of the focus and the appropriate focus on primary prevention. But if we look at the perfect storm of health issues that are coming at us globally, you look at conditions such as cardiovascular disease, #1 killer worldwide, stroke worldwide is the #2 killer, acute respiratory disease, #3, chronic pulmonary diseases, which everyone dies of acute exacerbations for the most part, #5, diarrheal diseases, which are amenable to acute care interventions, #7, and road traffic, #10, just by itself. And really, I think trauma as a totality, including non-accidental trauma, really is much higher. You look at these conditions, and these are conditions that are amenable to emergency care interventions. What are emergency care interventions? Emergency care is not a complete failure, it is secondary prevention. So if you have a prevention mindset, emergency care is a core secondary prevention mortality to prevent mortality and morbidity after the event has occurred, to reduce disability and death after the incident has occurred. And it involves many phases, including integrated systems, care at the point of injury or illness, at receiving facilities, and essentially takes a whole population approach to healthcare delivery, just like preventive medicine. What are some of the skills that make emergency medicine different from just a general practice or a generalist approach? Because after all, emergency medicine is a generalist specialty. Well, there's a very complaint-based approach that distinguishes it from other specialists, and the sorts of critical care interventions, the sorts of use of high technology when it's available are things that emergency care providers are trained in that distinguish them from basic general practice providers. So again, focus of emergency care is on secondary prevention. However, that is not to say that we cannot do primary prevention through an emergency care framework. In fact, there are a number of primary prevention activities that have been shown to occur quite effectively in emergency care settings, such as primary prophylaxis for tetanus, other vaccinations, injury prevention counseling. Here in Atlanta, the Emory Center has been amazing in that regard, substance abuse counseling and detection, and most recently, a significant impact in many countries, including the US, for HIV testing and screening, all happening in this setting. And this is not just my opinion, this is the opinion of the World Bank, the WHO, and who determined that 45% of all deaths and 36% of all disability was amenable to emergency care interventions. And these include ischemic heart disease, cerebrovascular disease, and unintentional injuries. In fact, the World Bank concluded that emergency care packages, which have really been ignored to a large extent within global health, is one of the 6 basic interventions required as a minimum package of healthcare services. And this is backed up by over 300 quality publications that show outcomes difference from various emergency department interventions. We know, for example, that in trauma systems, for example, can reduce mortality, and other emergency care systems up to 50%, depending on what you consider to be the definition of outcome, reaching the hospital alive, or deaths that can be medically preventable. In fact, the World Bank has estimated that 400,000 to 2 million lives could be saved annually only in the trauma system if you achieve the same death rate of approximately 14% that is true in the more industrialized countries. So we also know that this is cost effective. These trauma systems, less than $100 per disability adjusted life year. So in spite of this cost effectiveness, it continues to be a problem for low and middle income countries. Again, we also know that emergency care varies widely by region and the resources available. So why is this? Why is this? We have what is considered around the world a new specialty. In many respects, it's the oldest specialty. It's hard to believe that the first healthcare providers were not focused on acute conditions, on conditions that were diagnostically obvious, like bleeding, like shortness of breath. These had to be the first things that healthcare providers looked at, and if you look at the ancients and you look at the religious traditions, this is backed up. So we're really rediscovering in the last century this first specialty, which now is recognized as a specialty in over 60 countries with the rate accelerating on a constant basis. So what kinds of things are effective interventions on a system basis? Trauma centers, out-of-hospital triage criteria, protocols, and transfer agreements within a system to make sure the patients get to the best centers. And again, the World Bank has recognized this. The World Health Assembly has recognized this. World Health Assembly 6022 calls on all member states to improve their emergency care systems and to do comprehensive assessments of the emergency care needs, availability, and quality of existing services in their country. This is, of course, an unfunded mandate from the World Health Assembly, but it is one that is delivered with its full moral authority. And there are those standing by. The International Federation for Emergency Medicine, composed of the specialty societies in each country, are working on this and ready to provide the kind of technical expertise that's necessary to support developing countries or countries that have emergency medicine but are looking for tools to improve it. In addition, organizations such as mine, the American Heart Association, also have many of these tools available to help. But we need a gap analysis. In 1946-47, when the World Health Organization was established, emergency care systems were not top of mind, so they're not built into the annual assessments and the ongoing assessments of the World Health Organization, and there's very little known about the relative gaps in emergency care systems. This is a desperate need, and there's a desperate need to fund global gap analysis of needs in emergency care systems. So in conclusion, the people of the world really have a yearning for emergency care. There's no basic human need more than perhaps water than to have someone help you when you feel that your life is in danger. Emergency care systems do that. So this is something that the people want. Emergency care systems are developing rapidly, and there's great opportunity and reward for all of us who work together to integrate this critical role of emergency care into global health systems. So thank you very much. If you'd like to read more about this as an overview, I've listed a couple of references and be happy to talk to any of you at the break. Thank you very much.